Hit the subscribe button or visit us at auau.auanet.org.
All right, welcome. This is our course on genetic testing and prostate cancer. It's kind of like Vegas, except not at all. But here we are in front of our computers, and we really appreciate you joining us for this. This is a course we've given for a few years. It's a course that all three of us, or it's a topic all three of us are really passionate about, and very fortunate to be able to work with Dr. Gamilla and Dr. Cheng on this course. Just to start out with a few introductions. So I'm Todd Morgan, a urologic oncologist at the University of Michigan. Dr. Lenny Gamilla is here. I don't know if I actually have no way of knowing who's on screen and who's not, but maybe he's on screen right now. And if you can wave. He's a tremendous expert in prostate cancer genetics and prostate cancer in general, chair of urology at Jefferson. I've also listed our Twitter handles here, so if anybody wants to engage on Twitter, we're game for that too. And Dr. Heather Cheng, who's associate professor and directs the prostate cancer genetics clinic at the University of Washington and Seattle Cancer Care Alliance. Again, just an amazing medical oncologist with expertise in this space and really a true leader in this space. So really fortunate to get to work with Dr. Gamilla and Dr. Cheng on this course. And I know I always learn as much as anybody else doing this. Real quick, our disclosures, we've listed them here. I'll leave that up for a second for everybody to take a look. Advisory boards are listed, consulting is listed, and research is also listed here. Next thing we get to do is the pre-test. I also want to just highlight that there's a chat window up on the swap card. We're all logged in, we're ready, we're game. We don't mind pausing our lectures and delving into discussions, and I think discussions are always much more engaging than anything else online. So please post questions. We'd love to engage with you here. It makes it definitely, I think, much more exciting for all of us. So pre-test question 1. Which of the following, so these all get filled out online in the swap card. And I'm going to call that up too. So which of the following statements is false regarding genetic testing of prostate cancer patients? A, criteria for consideration of genetic testing includes family history of breast, ovarian, pancreatic, and colon cancer. B, testing can be performed with blood or sputum. C, multi-gene panel testing is covered by some commercial insurance providers. Or D, when somatic tumor testing has been performed, germline testing is unnecessary. I get to pause here for a few seconds. I've been known to fill this space with a joke, but I'll spare you. I don't know. Maybe I won't. We'll see. Next question, number 2. A 64-year-old man presents with metastatic prostate cancer. He has started ADT and is considering abiraterone and prednisone versus docetaxel. You perform pre-test counseling and order multi-gene panel testing in a urology or oncology clinic, and the test results reveal a germline BRCA2 mutation. It's pathogenic. Which of the following is false? A, it is critical to refer to genetic counseling for appropriate follow-up and cascade testing of family members. B, it is critical to refer to genetic counseling even if he only has only sons. Tailored clinical management should be considered for men with a BRCA2 mutation. C, based on current data, presence of a germline BRCA2 mutation should lead to prompt consideration of adding a PARP inhibitor and avoiding abiraterone or docetaxel in the hormone-sensitive metastatic setting. Or D, based on current data, presence of a germline BRCA2 mutation should be noted for clinical trials and future consideration of PARP inhibitors if he develops castration-resistant disease. So again, which of the following is false? I'll leave that up since it's a long question for another few seconds. All right, so what do you do with a sad astronaut? How do you make them feel better? You give them some space. There you go. I did it. There's one. Number 3, which of these treatments may be particularly effective for men with Lynch syndrome who have metastatic prostate cancer? A, olaparib, B, pembrolizumab, C, cisplatin, or D, enzalutamide? And then question number 4, the gene most clearly associated with increased risk of aggressive prostate cancer is A, BRCA1, B, BRCA2, C, ATM, D, MSH2. That's a quick one, so just give a few more seconds. And again, we'll come back to these at the end and review them as post-us questions with answers at that time. All right, so now to kind of get started with the real content, just to outline our learning objectives for this course, and they're also listed on the swap card site. First is to learn how to counsel men with BRCA1 and 2 mutations, Lynch syndrome, and other key inherited syndromes regarding their prostate cancer risk and appropriate strategies for cancer screening. We want to help describe the criteria for genetic testing of prostate cancer patients, the gene panels available, and options for testing these men. Help participants interpret results of genetic testing, understand how to relay this information to patients in order to facilitate shared decision-making based on the test results. And then to utilize the results of genetic testing to improve outcomes among patients with prostate cancer. And just big picture to kind of set up the next talks, I'd like you to think about, why is germline testing important, and what do we even bother thinking about this? And I think there's some really important aspects that are different than a lot of other tests we think about, and there's some overlap, of course. So one is risk assessment. We think about this a lot. What is the probability of somebody developing cancer or developing aggressive cancer? But here we can think about prevention. Is the disease risk modifiable? So specifically, is the risk of prostate cancer modifiable? I don't think we yet have great answers there, but hopefully we'll touch on it. Prognosis, do germline alterations have an impact on prognosis? Yes, certain ones do. Cover that. And treatment selection, are certain treatments more or less effective in the setting of specific mutations? So are certain mutations akin to predictive biomarkers? Do they predict response to specific treatments? Again, yes. And then familial risk and testing. This is another area where germline genetics is really distinct from a lot of other markers and tests we think about. What is the impact of these tests and test results on family members? So the outline for this course, I just gave the introduction. Dr. Gamella is going to review basic concepts of genetics in general and genetic testing and the impact on prostate cancer screening. I'll review the implications for localized prostate cancer with a focus around practical applications, how we use this test in our practice as urologists. And then Dr. Cheng will talk about the implications for genetic testing in advanced prostate cancer. We have time throughout for Q&A. Please, again, post questions in the chat. I'll keep an eye on that. And with that, I'm going to turn this over to Dr. Gamella.
Well, great. Thanks, everybody. Sorry for the technical glitch, but it's great to be with everybody. And it's certainly an honor for me to be on the same program with Dr. Morgan and Dr. Cheng, who are really luminaries in this field. My job the first 20 or 25 minutes is just to sort of bring you back to college, maybe first year of medical school, and go over some very basic concepts in genetic and genomic testing. So why is this all happening? This is all happening thanks to our government. The NIH started the Human Genome Project in 1990 and completed almost all of it by 2003. It mapped the entire human genome, not a small job, 3.2 billion base pairs in the human genome, which took many, many years to decipher. But another interesting thing happened. And what happened in 10 years later in 2013 were two interesting things. One was the Angelina Jolie effect. And what does that mean? Angelina Jolie brought to the world the fact that you could inherit prostate cancer and brought the concept of BRCA inherited cancer risk to the world. About a month later, another interesting thing happened, and that was the United States Supreme Court ruled that DNA, both naturally and mutated, could not be patented. Why is that important? Because before 2013, one company mostly controlled the BRCA1, BRCA2 genetic testing world. And then after that, it was like somebody shot a starter pistol, and many, many, many other companies got involved with genetic testing for prostate cancer. So to put this in perspective for urology, if you go back to before 2016, prostate cancer and BRCA were only discussed in the hereditary breast and ovarian cancer guidelines. It was not until 2016 that the first mention of family history and BRCA1 or BRCA2 were mentioned for screening. Since then, as we'll talk about, many other iterances of the NCCN guidelines now discuss a whole variety of aspects of the use of genetic and germline testing in prostate cancer. So we're very pleased that here in Philadelphia, we were responsible for one of the first international consensus meetings to address this. And our faculty that we're on the program with today have participated in some of these programs. We're planning on another one in 2022, focusing specifically on the underrepresented minorities. So we'll keep you posted on that. I'm very pleased to run a lot of these meetings with Dr. Vita Giri, who's really been a teacher for me of genetic testing and genetic counseling at Jefferson, is responsible for a lot of the work that we have done at Jefferson. So these are the four major topics that we're going to cover in my introductory course to talk to set the stage for Dr. Cheng and for Dr. Morgan. First thing we're going to talk about is the most basic concepts, and that is genetics and genomics. So traditionally, genetics is the study of individual genes and their inheritance. Most of us know this from Mendelian inheritance, sickle cell anemia, cystic fibrosis, where a single gene has caused a disease to develop. However, modern genetics now really looks at panels of genes and inheritance patterns. The term genome refers to an entire set of genes in an organism. And when we use the term today, genomics, it's really genetics and genomics used as common terms, because genomics really refers to the analysis of genes interacting with each other and with their environment. So when we use the term genetics and genomics today, they're almost synonymous with each other. And again, remembering your basic high school or college biology, DNA is made up of many base pairs. As an example, a bacterium has 600,000 base pairs, and humans have greater than 3 billion base pairs, 23 chromosomes, all comprised of the 3.2 billion base pairs. An interesting concept is that genes are the sequence that make proteins, and only 2% of all of our human DNA makes proteins. And most of our DNA we have is non-coding. I mention that because as the years go on, we're going to study more and more and learn more about this non-coding area of our DNA that's probably going to lead to new breakthroughs in all diseases, including cancer. So terminology, a BRCA1 is the natural gene. If we say BRCA1 or BRCA1 mute and mutee, that is the mutated gene. It's important to understand there is not just one mutated gene. There are hundreds and hundreds and hundreds of mutations that occur in our BRCA genes, our ATM, our check genes that we will talk about. So exons are the DNA sequence that makes proteins. The intron is sort of the dark side of our DNA, does not encode for proteins, but we're trying to learn exactly what they do. For completeness sake, I just want to mention to you all the term SNP, which is single nucleotide polymorphisms. I discovered yesterday, if you looked up SNP on Google, it only talked about vasectomies. But in our expression here, Single nucleotide polymorphisms are variations in the DNA sequence. And these are things that lead to changes in eye color and blood type. And polymorphisms are when these occur in the DNA of at least 1% of the population. So there is growing evidence about single nucleotide polymorphisms. They're not mutated genes, but we'll leave that on the side right now because it's an evolving area in management of prostate cancer. And lastly, epigenetics. Epigenetics are the study of changes in a gene due to an expression in the gene being turned on or turned off. These are usually caused by something known as DNA methylation. They are not mutations, but they turn the gene on and off. These are important in the management of patients with cancer. For example, the confirmed MDX tissue assay relies on the methylation in deciding if you're near a malignant area in the prostate. But again, when it comes to genetic testing for risk or management right now beyond diagnosis, epigenetics is not used. So karyotypes, major chromosome breaks, translocations are something that have been with us since the 1940s. This is still done in areas such as pediatric risk assessment and in pediatric genetic testing. But most of the chromosome changes we're talking about today cannot be detected unless you use molecular techniques. So here's an example, computational biology. The example shown here is a normal BRCA2 gene. This is just a small portion of the gene that is 12 pages long. You might imagine it is humanly impossible to pick up subtle base pair changes in this gene without the use of computers. So mutated genes such as the mutated BRCA2 gene can actually have many hundred different reported sequences. And there's something known as the gene bank that is managed by the NIH that is the repository of mutated genes that genetic counselors and other investigators go to see if their discovery of an altered gene sequence is something that is clinically important. Last thing just to mention is something known as deep sequencing or next generation sequencing. With these literally hundreds upon hundreds of gene altered base pairs, reading the sequence many times over minimizes the chance that you're going to end up with a read error. And the gene chip technology has now taken this into the 21st century. And in fact, many genes are now sequenced at once. So it's actually cost effective now to look at several hundred genes at the same time instead of one gene. And the expression I like to use is recreational testing. Patients can go out there and pick up all sorts of things off the internet or the CVS pharmacy. They are unlikely to deep sequence. But again, when you're looking at things like, will I like broccoli, or am I beautiful to my girlfriend or boyfriend, they're unlikely to do deep sequencing because if you mess up a couple of sequences, it's not going to matter. But medical labs that go for very low cost, except for a few, you've got to be very mindful of when it comes to genetic sequencing. So this is my take on the modern tumor evaluation, going from imaging to gross pathology to histology to the cell and the nucleus. Today, we're down to tumor evaluation looking at genomic analysis. It cannot be done visually. It can only be done using the molecular techniques that we talked about. Now, this is a must-remember slide. If you forget everything from my first introductory talk, please remember this. There are germline mutated genes and somatic mutations. These are very important concepts that are getting more and more important in urology and urologic oncology. Germline mutation is what you inherit from your parents, and the mutated gene is in every cell in your body except for your red cells that don't have any DNA. Somatic mutations are very different. They are acquired mutations. They guide therapy very often. And what I usually express these as, it's the Wild West of a tumor. Any gene can go awry in a tumor, but you cannot transmit a somatic mutation to your offspring, whereas a germline mutation can be sent to your offspring. So if we look at our buckets of prostate cancer genetic testing, we have genomic profiling, tumor sequencing, and inherited cancer risk testing. Profiling is something we're very familiar with in urology. These are proprietary molecular genetic signatures from the manufacturers that are notated here that help us guide treatment and management. Genomic tumor sequencing is something that's really now exploding in urology and urologic oncology, where you look at an extensive panel of mutated genes, and many of them are 300 genes or more in the tumor itself. And a new concept that we'll touch on briefly is known as liquid biopsies. Circulating cell-free DNA or circulating tumor cells in your body can actually be picked up through a blood test, and you can sometimes sequence the tumor just based on a blood test. Traditionally, these are used for clinical trial eligibility and developing today targeted therapy. Lastly, and something we're going to spend a little bit more time on, is inherited risk testing. This is to identify those inherited germline mutated genes that can be passed along to your offspring that may increase cancer risk. And they will have, as I and others will talk about today, increasing role in screening and cancer prevention. So here's an example of something known as the Foundation 1 liquid CDX biopsy. This can actually be done with a blood test, but more commonly, somatic testing relies on biopsying a tumor or a metastasis and then subjecting to it an extensive gene panel. Not only will this identify mutated genes, it will also identify things known as actionable genes such as tumor mutational burden or microsatellite instability that we'll talk about later that can actually drive treatment. So somatic tumor testing, again, is mostly commonly used to identify actionable genes, mostly for clinical trials. Why is this getting so important today in urologic oncology? Because of PARP inhibitors and pembrolizumab that'll be discussed a little bit later. Medical oncology is far ahead of us in using somatic DNA tumor testing to guide treatment, but urology is now finally catching up. And again, this evolving role of liquid biopsy, very nice work done by Dr. Wyatt up in Vancouver, British Columbia, has shown a high concordance of metastatic tumors detected by liquid biopsy and a matched biopsy of the main tumor. So again, very exciting area, not quite there yet for everyday use, but certainly it's growing. So the actionable genes that we can identify in mutational testing in prostate cancer are things such as BRCA1, BRCA2, as well as DNA mismatch repair genes, also known as the Lynch syndrome sequence, where patients would be available with advanced prostate cancer for drugs such as pembrolizumab. So this concept of microsatellite instability looks at altered genes that are responsible for repairing errors of genes, and they're unable to fix DNA replication errors. This is also known as DNA mismatch repair. And again, why is this important to us in urology? Because this is why pembrolizumab can be used as a third or fourth line agent. Last concept to discuss is something as VUS, which is a genetic variant of uncertain significance. If you order your own DNA testing and you don't work with a genetic counselor, you need to be very familiar with this concept, because these genes are not known to be abnormally mutated or cause disease, but there's something that you need to review as time goes on and make sure that this gene does not come up a year later on the gene bank as saying, hey, this gene has now been associated with a deleterious mutation causing genes. Again, so VUS is something, if you get a VUS back on a gene report, you need to make sure that you monitor that patient for follow-up. Next, I'm going to talk briefly about prostate cancer and inherited risk. At the end of the day, the majority of prostate cancers are still sporadic with no known genetic component. A smaller percent, 15 to 20%, sort of smell like there's a genetic alteration. Maybe there's one relative with breast cancer or ovarian cancer. We're going to focus on hereditary cancer. This is where there is clearly a mutated gene that has been passed down from generation to generation. While this is only 10 to 15% of our prostate cancers, they are very important because these mutated genes greatly increase not only lifetime risk, but increase the risk of the patient and their family developing other cancers. Another key concept, these mutated genes, such as mutated BRCA1 or BRCA2, do not cause cancer, but they do increase the risk of cancer and increase the risk of other related cancers in the individual and in the family. And as Dr. Morgan mentioned, genomic and germline testing may have a potential impact on not only therapeutic options, but screening other members of the family. This is the list of common genes. The tail of this is very long, but these are the top 10 or 12 genes that are associated with increased risk of prostate cancer. You'll note most of them have something to do with DNA damage response, DNA repair. One of them, the HOXB13 gene, has to do with an androgen receptor alteration, and this is the gene that is associated with clearly inherited high-risk prostate cancer, where you have many men at a young age who develop high-risk and often metastatic prostate cancer. Now, this is another concept, DNA damage response and repair genes. This is what is altered in prostate cancer. Those genes, such as BRCA1, BRCA2, check, are altered and make it more difficult for a altered DNA, either a single or a double-stranded break, to repair itself. Why is that important? If this is a cancerous condition in this cell, it can't go back to a normal state, and it will continue on its malignant pathway. So this is very, very important work. And Colin Pritchard happens to be a spouse of Dr. Cheng, who discovered germline mutations in metastatic cancer. You can see here BRCA2, ATM check, and BRCA1 are at the top of the list. Germline mutations, metastatic prostate cancer, very important, as we'll learn from a therapeutic approach. So again, these mutated genes are DNA damage response genes. They increase the risk of aggressive cancer. They're more likely to have Gleason 8, have node-positive disease, and we'll see poor survival. And they also increase the risk in other family members of hereditary cancers. Remember, only 10 to 15% of patients, but when you find this, it's very important. Anybody who doesn't believe germline mutations are important should review this paper by Bill Isaacs. And if you look here, if you have a germline mutation, you tend to die up to 10 years before with the germline mutation than if you don't have a germline mutation with prostate cancer. Very provocative information. The risk in ladies with these mutated genes is much higher than in men, but nonetheless, when you find it in men, they're at increased risk of prostate cancer, pancreatic cancer, as well as male breast cancer. Inherited germline mutation genes also increase the risk in family members who also have this gene. And again, very important to keep that in mind. Next, I want to talk about practical considerations in genetic testing. We have commercially available panels from our friends in industry. Many of them have prostate cancer specific genetic panels. Others, as you can see here, have general cancer panels that look at risk of cancer, but they tend to have our common genes that we talk about in prostate cancer, although they're not specific for risk. We, in 2014, started with my good colleague, Dr. Vita Giri, and our multidisciplinary clinic, a prostate cancer genetic program that we work with patients. But these are also from Dr. Morgan, has a genetic cancer risk clinic at the University of Michigan, and Dr. Cheng at the Fred Hutch Cancer Center at Seattle also has a very, very comprehensive program that actually extends nationally through her work, and I'm sure she'll talk about that a little bit more. So I'm a big believer in genetic counselors. As a urologist, I depend heavily on Dr. Giri and her team at Jefferson because it's a complicated world. And I think that we can order the genetic testing, but if we see an altered gene, I think it's very important to have a professional counselor involved with the patient. For example, when I look at this family profile here, this family tree, with some prostate cancer, with some colon cancer, I'm not exactly sure who should have genetic testing. If anyone else in the family at all should have it, that's why I like to rely on our genetic counselors. The last thing to mention is you got to be very familiar with what's known as the Genetic Information Non-Discrimination Act, or GINA, if you are ordering genetic tests, because this prevents genetic discrimination in health insurance and employment. However, look at the bottom. It does not protect against discrimination in life, disability, or long-term care insurance. So these are things to keep in mind if you feel comfortable ordering genetic testing. Lastly, in the next couple of minutes, I'm just going to briefly touch on the emerging role of genetic testing in prostate cancer, which is really going to be a focus of Dr. Morgan and Dr. Cheng's talk. The role of genetic testing in prostate cancer is becoming important when it comes to screening, active surveillance, treatment decisions at all stages of prostate cancer. We use genetic and genomic testing sometimes to confirm a biopsy is in fact from a patient that we think it's from. And most importantly and most excitingly, Dr. Cheng is going to fill us in on precision medicine for advanced therapeutics using PARP inhibitors and pembrolizumab in advanced prostate cancer. Very happy that we just had a paper in JCO Precision Oncology that came from many institutions, from Jefferson in particularly, and other centers around the United States. Dr. Geary is very proactive in genetic education testing for both patients and providers, and this is paving the way for more online educational programs for both patients and providers to understand genetic testing and how it should be used in prostate cancer. So in summary, why are germline and somatic testing important? We talked about it increasing the risk of certain types of cancers, and most importantly, aggressive cancer. Can the disease be prevented? As Dr. Morgan mentioned, we're not quite there yet, but clearly if you identify somebody at risk, let's say with localized prostate cancer who has a highly mutated gene, maybe preemptive treatment may prevent them from developing metastatic disease. Certainly, we've clearly shown that it gives us prognostic information. Is the disease aggressive or indolent? And lastly, the very exciting area that Dr. Cheng will talk about, can the treatment be individualized, particularly in the era of precision medicine? If you're going to look at germline testing in a family, here's just some of the general guidelines. Multiple patients with early prostate cancer, greater than 3 first-degree relatives, regardless of the kind of cancer they have. Any patient with aggressive Gleason grade cancer, metastatic cancer, castrate-resistant, intraductal cancer should undergo germline testing. Active surveillance should be strongly considered, and I think maybe Dr. Morgan will talk a little bit about that. If you happen to have Ashkenazi Jewish background, and again, we mentioned the Ashkenazi Jewish because they were the founder genes of BRCA1 and BRCA2 in the mid-1990s. In this population, they showed us the first inherited risk for breast and ovarian cancer in this population. So germline testing is recommended for basic prostate cancer if it's high risk or there's strong family history. Somatic is recommended in men with metastatic cancer, either locally advanced or certainly castrate resistant. So in conclusion, I think we have some very rapidly evolving recommendations for prostate cancer genetic testing. You see the most critical genes today that we talked about, but there is actually a long tail of many other genes that we're investigating. High prevalence of germline mutations, at least 11% in some recent studies show as high as 20 to 25% in metastatic castrate-resistant prostate cancer. All men with metastatic and high-risk disease should be offered germline testing. Somatic should be considered as well, particularly if they have advanced disease. And again, I'm a big believer in genetic counselors helping us with leading genetic testing and giving us the best approach in these patients. So again, thank everybody very much, and thank the honor of being here with Dr. Morgan and Dr. Cheng today to discuss this topic. So thank you for listening.
Thanks, Lenny. That's such a good talk. I mean, that's just it covers so much foundational knowledge, and really it explains a lot of just the why we're doing this and the biology, and it really does set the stage. And Yeah, I think that it just doesn't get better than that in I think in a way that all of us can understand. So thank you. Tell me, do you in your practice, if you see a man who you recommend genetic testing to, and that man says, yeah, I'd like to go genetic testing, do you refer, or do you proceed with counseling and ordering the test?
Yeah, so when we see patients in our multidisciplinary clinic, they get a preliminary 5-minute, letting them know that genetic testing is available, but we don't usually do it initially. We let them be treated, we let them to decide what they're going to be doing, and then reintroduce it to them several months later if they're interested. We give them a card to call back our genetic counselor.
Yeah, so then
we let them order the tests in our shop.
The genetic counselor will go ahead and order the test. And then so if we'll talk more about this, but I think one of the challenges is when you get a VUS result back. So that's the gray area, right? And then that result needs to be tracked, because then the VUS will get reclassified someday as mostly non-pathogenic, but every once in a while it'll get reclassified as pathogenic. So do you guys have a workflow in place for that?
So again, that goes back to my mantra that I'm not sure urologists should be deeply in the deep end of the pool when it comes to genetic testing, because a genetic counselor will be in the area where they're checking the VUS. If a patient comes back with a VUS, they'll go back into the gene bank and see if it gets reclassified. I think for urologists, it's a little tricky for us to do that. But again, I do understand there are some urologists who are comfortable with following up on things like VUSs.
Yeah, Dr. Cheng, what's your practice pattern for the VUS? And I bring it up partly because we've been talking a lot about it here. Like, are we doing a really excellent job with this issue? And because it's a challenge. So what's your workflow for keep an eye on those VUS reclassifications?
I think it absolutely is a challenge, and the history of the VUS, we won't have time to go into it today, is one that kind of makes me think about whether we really should be reporting it. And that's sort of a separate discussion, but if it's not clear, sometimes it's not helpful information. But to answer your question, I think it's not perfect. So our counselors will try to track it, but you can imagine if it's decades worth of testing, sometimes the tests don't always, we don't have the contact information for the patient. They do get reclassified, but we can't track them down. Maybe they've changed healthcare systems. Maybe they, are lost to follow-up. So it is a real challenge. I think we also tell patients to, if there is a VUS, there is also a discussion about asking them or informing them that they may want to keep their, report and then, check back in a couple of years. But I feel like that's inadequate. So I think the system as a whole, and maybe with electronic medical records, we can try to do a little better. We are working on a registry, and there are existing registries for VUS, like for other cancers. Like there's a registry called PROMPT. We're developing one for prostate cancer to sort of address some of these questions. But you're absolutely right. I mean, most of them are benign, meaning they get reclassified as not harmful, but then some are harmful.
Yeah.
And that's actually more likely in people who are from populations underrepresented in the current databases. So that's the other kind of piece that we could discuss further. But I have a patient who had a very strong family history of breast cancer and prostate cancer, 53, with high-risk localized disease and developed metastatic disease, had a BRCA2 VUS. His sister was being treated in her 40s for breast cancer in Ohio. I think we have somebody who is from Ohio. And we enrolled him, actually the family, in a study, and we reclassified the variant, which is actually one of the most common African-American variants that are out there. So this is why it's really important to be thinking about this as we kind of launch some of these new initiatives. It's definitely exciting, but there's a responsibility that goes with it.
Yeah, for sure. I mean, I'm glad I just kind of looked out of the corner of my eye. Stacy Loeb just chimed in, who's got tremendous expertise in this space, and really highlighting that this is a complex issue. And I think, again, the purpose of this course, as much as anything, is for urologists to be able to discuss genetic testing with patients, to be able to recommend it to the patients who are appropriate within guidelines to consider undergoing genetic testing, potentially to be able to do the counseling ourselves if we're comfortable with it, and we can again follow guideline-based practice in doing that. But there are all these little complexities, not little complexities, they're real complexities.
Yeah,
And
Todd, you just made me think of something. Most of us that are in academic medicine that do urologic oncology have done fellowships, and our fellowships often involve working with basic scientists, not because you're going to be a basic scientist, because you understand the lingo. So to your point, we need to understand the lingo as urologists, even if you're not doing your own genetic testing.
Yeah, exactly. That's very well said. So I'm going to go ahead and share my screen. I think. And so that's right. So there's gradations for how deep we get into this, but anybody who's here, it's because they want to be able to converse on this issue with patients. And if we as urologists we're front lines for at least patients with localized disease and often for patients with metastatic disease. And if we don't bring this up, the patients may never hear it and may not know. And so we have to be able to identify the patients, and potentially we can do the counseling, but we don't have to. We can refer to genetic counselors, but the more we understand, the better job we can do. So this part of the course is really about practical considerations for germline testing and how we as urologists can embrace this issue. And I think really, key questions are: which patients with localized prostate cancer should undergo genetic testing? How do we implement it? Should we treat patients with low-risk prostate cancer differently if they have a BRCA mutation or another related mutation, mutation in another DNA damage repair gene? Should we treat patients with high-risk localized prostate cancer differently if they have one of these mutations? And before we kind of get deep into the DNA damage repair genes, I want to go back to what Dr. Gamella talked about with SNPs, because there are multiple different facets to prostate cancer risk. And I think this pyramid here of that kind of describes the SNPs, which are these smaller changes that are often, we don't understand the mechanism. They're in non-coding regions of the DNA, but they still carry genetic risk, kind of incremental risk, often compiled together into these genetic risk scores. And I suspect that we'll be seeing a little bit more of this over time, because we can use that to categorize how at risk a patient is of developing prostate cancer. And then higher up are these rare uncommon variants with a moderate effect size. So when there's a mutation in one of these genes, these are the ones we're focused on really in this course. When there's a mutation in one of these genes, the risk of developing prostate cancer is substantial, so a moderate effect size. I think this is the one slide that I wanted to show that really talks about SNPs. And I think it's pretty fascinating data. This was published just this last year. And so it was from a large prospective cohort derived from the UK Biobank. 200,000 prostate cancer diagnosis-free participants were included in the registry, and then they tracked family history, the rare pathogenic mutations like BRCA 1 and 2, CHEK2 is in here, OXB13 is in here. And so that's the RPMs. And then the genetic risk scores are also included. And the question is, when you control for all of these, are they all independent predictors of prostate cancer incidence and mortality? And when you look at this data, you can see that here's for incidence, every single one of these, family history, the rare pathogenic mutations, and the genetic risk scores are all independently associated with prostate cancer incidence. So that gives some insight into that all of these issues are important. Family history on its own is important. All these mutations on their own are obviously important. And so are potentially SNPs. But really, again, what we're talking about here are the BRCA1, BRCA2 mutations, ATM, and people say, okay, what proportion of patients with prostate cancer have one of these mutations? And very roughly for BRCA1, it's about 0.5%. And this is with localized prostate cancer. BRCA2 about 1%, ATM about 0.4%. But as Dr. Gamella said, these are much more common in lethal than in non-lethal localized prostate cancer. And when you look at studies that that enrich for patients who undergo testing. Of course, they're going to enrich for much higher rates of mutations, and we'll show some data around that. So again, very practical standpoint, who are the patients that we should be bringing this up with? And Dr. Gamella showed some of the guidelines. I want to highlight this again. These guidelines change. There are multiple different guidelines. I think the NCCN genetic and familial high risk assessment guidelines are really, really good. They do not say anything about prostate cancer. And so that's the warning. It's the breast, ovarian, and pancreatic cancer guidelines. These are getting more and more like the localized prostate cancer guidelines. They're kind of coming together, but I always keep an eye out on these guidelines because they're really excellent. They are really specific about germline testing and prostate cancer. So, we saw this already from Dr. Gamella. I really want to spend a few seconds going over this because if nothing else, these are the patients when we see them in our urology clinics that we need to be bringing this up with. And so we can, who do we need to talk with? Well, it's patients with a history of prostate cancer who have any of these three things: metastatic disease, intraductal or cribriform histology, or high or very high risk disease on their own, not even thinking about family history. So that's really important. And then here by family history and ancestry, so patients not meeting those criteria, but who have, say, low risk, intermediate risk prostate cancer, and they have a close blood relative with breast cancer at an early age, or ovarian cancer, pancreatic cancer, history of metastatic or high risk prostate cancer, or two close blood relatives with breast or prostate cancer. And ultimately, I think the family history guidelines themselves, they do get challenging as you like, well, is it the same side of the family? But I just encourage people to keep the gestalt in mind, like look at this, but keep the gestalt in mind that patients with prostate cancer and a strong family history of any of these cancers, so we're not just asking about prostate cancer, need to have a discussion about genetic testing, and also patients with Ashkenazi Jewish ancestry that Dr. Gamella already highlighted. And then lastly, really for any patient that we see in any setting, mutation identified on somatic tumor genomic testing that has clinical implications if identified in the germline. So basically, for example, a patient with somatic tumor testing that shows a BRCA2 mutation, that on its own does not mean the patient has a germline mutation, but we don't know. And the only way to find out is for that patient to also undergo germline testing. So that's really, really important. Now, I mentioned that the localized prostate cancer guidelines are getting closer to looking like the familial guidelines. I just post those here. This is basically the same concept shown a little bit simpler. Again, just really emphasizing that for high risk and metastatic disease, we need to be broaching the topic of germline testing, bringing that up with patients, whether or not we're doing the pre-test counseling or referring to genetic counselors. It's really important for us to bring this topic up. For patients with lower intermediate risk disease, again, recommending a strong family history or intraductal or cribriform histology. So, what can we expect when we deploy germline testing in clinical practice? So this is a study of patients who underwent germline testing for prostate cancer. It was a mix of advanced disease and localized disease and a mix of probably family history data that we don't necessarily have. But if you just kind of look and say, okay, what are the types of findings that we're going to come across and how often? In this study, it was 17% of men were found to have a germline variant, and one of the genes that is either known or thought to be associated with prostate cancer or aggressive prostate cancer. You can see the different genes that are highlighted here. BRCA2 was the most common, CHEK2, ATM, BRCA1's further down. And when you compare this with Colin Pritchard's really important paper from, I don't know, what was it now, 5+ years ago, that looking in patients with metastatic disease, this looks very similar, right? So the mutations that we see early on in these patients, at least, some of these patients have localized disease. A large proportion of them likely look a lot like the same frequency of mutations that we see later on. All right, so how do we do it? So let's say that I, as a urologist, really want to take this on and help patients undergo germline testing. So as a first step, we need to define the criteria for testing. We've talked about that. Highly recommend both NCCN guidelines and the Philadelphia Consensus Conference guidelines. Tons of overlap there. 2, I'm going to talk about the importance of a family history. discuss how we're going to counsel patients. We need to think about issues of insurance coverage versus fixed out-of-pocket costs. And so just to briefly touch on that, insurance coverage is highly variable still. It's getting better. But many of the companies that offer testing do offer programs with fixed out-of-pocket costs, often in the range of $250. And so it's a far cry from what used to be $3,000 or $4,000 for these types of tests. If we're going to take this on of ordering the test, we'll talk about how to do that. And then this issue of genetic counseling, if there's a positive test, potentially if there's a variant of uncertain significance. And we got into, conversation about that just a few minutes ago. So just, to kind of now circle back to family history, it's really important. I think for most of us as urologists, it's not our forte. I'm not saying that we have to make a pedigree, but we do have to think beyond just do you have a family history of prostate cancer? We have to think about how old was your family member at the time of diagnosis? Did they die of their cancer? Was it metastatic? The way that we've approached this in our clinic is with the help of our genetics team is a pretty simple form, but it's very different than the one we used to have. And I'm sure everybody has a different approach to this, but it does list the cancers that we feel are most relevant for these patients. And it asks, which relative, which side of the family, age of diagnosis. And we also ask about aggressiveness, metastatic disease, and death from cancer. So again, we're trying to get away from this patient has no family history of prostate cancer and move on. What are the other really key components of clinician-directed counseling? So that means if we as clinicians are going to be doing the pre-test counseling. So in addition to identifying the patients, we need to explain the purpose of the test, some description of the genes tested, review the accuracy of testing. So yes, these are mostly accurate tests, but also yes, some mutations can be missed. And a false positive is theoretically possible. And so we need to consider that. We review possible testing outcomes. And so here the important thing is we need to talk with patients that yes, it may be positive. Most likely it's going to be negative. The vast majority of tests are negative, but there's also this gray area. And I mention this to any patient who decides to or is thinking about undergoing testing, that there is a possibility of this gray area diagnosis, and that's a potential downside of testing, that we could get a variant of uncertain significance, and that just leads to more questions, as Dr. Cheng mentioned. Discuss testing options. What does that mean? Well, we've got blood tests and saliva tests. There's really no difference. Discuss genetic discrimination risks, and so that's really, really important. We review that. Everybody gets a handout on the GINA law and kind of the caveats to that Dr. Gamella mentioned. And then again, if the patient wants, then we'll go ahead and order testing. After the result comes back, it's so important to discuss results with patients. We can't order a test and not give the results with a genetic test. It's potentially, it would be obviously a huge deal to not provide that result back to a patient. We think about how it impacts recommendations around treatment, how it might impact screening recommendations for other malignancies. This is where we really rely on our genetic counselor collaborators. So any patient, again, in our practice with a positive result or a variant of uncertain significance sees a genetic counselor, and they also guide cascade testing of family members. And so, these are really important pieces of the puzzle. And I just want to mention here that this is very different than the other tests that we order, like genomic testing that Dr. Gamella mentioned, the Deciphers and Polarises and Oncotype DX that have no familial implications. And so where we might order one of those tests with a pretty limited discussion, we cannot order this test without a real discussion. It doesn't take that long, it's doable, but it needs to be a detailed discussion that covers all of these topics. I also just wanted to give a brief shout out to this registry. This is led by Dr. Geary, and Dr. Gamella mentioned that, she's a really huge leader in the space. We give all of our patients info on this registry. It's a registry for men who are undergoing genetic testing. The only way that we're going to learn more about what to do in this setting is through sharing data. Men are very interested in participating in this, and so I just wanted to leave this up here for everybody to see and to consider encouraging your patients to participate in this registry if they're undergoing testing. So now the logistics, what do we do to order a test? Again, it's a blood or saliva test. There are many different panels. Dr. Gramella showed a slide with the different panels. There's no known panel that's better than another. They all include kind of the basic genes like the ones listed here, ATM, BRCA1 and 2 and CHEK2. And yeah, there's going to be some nuance in other genes that are included in the panel. But they're going to, at some level, they certainly do all have the most important genes, the most relevant genes in prostate cancer. The results can be positive, they can be negative, and they can be this variant of uncertain significance, which we treat as negative until further information is available. Now, one more word of caution is that there are 15 gene panels, and there are 20 gene panels, and there are 80 gene panels, and more for sure. And you might think, well, this is great. I can get the 80 gene panel and it's the same cost as the 20 gene panel. Why not just let's go for 80? And just keep in mind, more isn't always better. Yes, you might pick up mutations in genes that you wouldn't have otherwise seen, but you'll also find mutations that you have no idea what to do with, no idea what their impact is for that patient. And so that can lead to anxiety, further questions, of course, more likely to find a VUS, the more genes you test for. And so that's just another word of caution around going for it's not all about bang for the buck, getting the most genes for a fixed cost. And that at the bottom, just one more reminder that all patients with a pathogenic or likely pathogenic test result or a variant of uncertain significance really should be referred for genetic counseling. And now many will make that referral from the outset. Other urologists I know are doing the counseling, ordering the test, and then making the referral as needed. In our practice over the last few years, we've had an IRB approved protocol prospectively just asking the question, if we do the counseling, how good a job can we as urologists and medical oncologists do? We've had used some validated survey instruments to ask the question after a patient undergoes counseling and after they undergo the testing themselves, are we meeting those criteria that I set out? Are we discussing the alternatives to testing, and are we discussing risk of genetic discrimination, and are we discussing the accuracy of the test? And I think just big picture gestalt, green is good, other colors mean purple was no. We can do this. Can we do it? Are we doing it perfectly? Absolutely not. Can we improve? Absolutely. And we can learn from this. But in general, I do think we as clinicians can learn to do a good job with genetic counseling in the clinic for these patients. At the end of the day, the genetic counselors are still very much the linchpin in this space, and we rely on them tremendously. I do also want to highlight this paper from the PCCTC, Dr. Cheng and other leaders in this space are on, that just highlight the barriers, what keeps us from really doing a great job in this space. And I think kind of reaching our ideals in terms of offering all the patients that should be offered genetic testing, being able to offer it to them. Access to genetic counselors is a big issue. Education is a big issue. So thank you everybody for participating in this. Time, we have a very finite amount of time, and this does add time to clinic visits. The cost and insurance issues are often confusing, like everything else, and anything new is difficult. And so that from both the cost insurance standpoint and just impacting our overall workflow, how we get things done in the clinic, it's hard to change. And so those are really important barriers that we need to keep tackling. And so last, I just want to briefly mention kind of how does all of this knowledge, how does this impact how we treat patients with low risk prostate cancer if they have a mutation in, say, the BRCA or another one of these genes? And should we treat patients with high risk localized prostate cancer differently if they have one of these mutations? As you've seen already, patients with mutations in the BRCA gene have worse outcomes. It's a much more aggressive disease. So this is comparing patients with mutations to patients without in the setting of localized disease. These are patients who underwent either surgery or radiation. And so BRCA status was associated with a threefold increased odds of metastasis and prostate cancer specific mortality. Here's another study. This one was already shown. patients with BRCA1 or 2 mutations or ATM mutation carriers are more likely to die of prostate cancer, both for whether they have advanced or localized disease or just a localized only cohort. So these mutations are absolutely associated with more aggressive disease. And then there's this one, which I kind of think is food for thought. It's an important study, but kind of if you look at the numbers of patients, keep that in mind and keep that as you look at this data. So these are patients on active surveillance, looking at mutation carriers to non-mutation carriers in orange, and we're looking at the cumulative incidence of upgrading on the y-axis over time. So this is out to 10 years. On the left, it's patients with BRCA1, 2, or ATM mutations. On the right, it's BRCA2 mutations. And you can see that the cumulative incidence of upgrading is greater in mutation carriers. And I, again, would just caution it around the low numbers. So only 11 total mutation carriers with 11 total BRCA2 mutation carriers in this cohort. And also the event here upgrading is of important, but maybe it's not the be all end all in terms of how important and relevant it is as an endpoint in this setting. So that's kind of a word of caution. And so really here, this is my summary slide here, which is that, okay, and we'll see how, if we have a couple minutes at least for discussion. In low risk disease, we'd say, okay, is active surveillance still appropriate if somebody has a BRCA2 mutation? And there I would say, yeah, appropriately counseled and discussed, and with intense surveillance and taking all the tumor factors into account, I would say that data is not enough for me to necessarily recommend against active surveillance in the setting of low risk disease and the BRCA2 mutation. And then on the other side, it's okay, well, how about in high risk disease? What are we doing? And I had a patient very recently with a BRCA2 mutation who's very young, and prostatectomy was T3B, 2 out of 15 nodes were positive, incredibly aggressive disease. And so what do we do differently? Well, the answer is these are the patients with a clear need for multimodal treatment and a clear need for clinical trials. And so hopefully we'll continue to push all of that forward in the coming years. So I'm going to stop my share here. Bring everybody back. Yeah, okay, now I can see my Zoom screen. So yeah, if Dr. Gamel and Dr. Cheng want to pop back on and we can chat for a second. So I have not been able to keep an eye on the chat, but I see that you guys have. So thank you for doing that.
So Todd,
Talk to me.
can we drill down a little bit more on localized prostate cancer? Your thoughts about, a 55-year-old gentleman who has a sister with breast cancer, and that's why he got tested and then found out to have prostate cancer and has the germline mutation. How much does that weigh into your recommendations in this 55, 60-year-old gentleman?
Yeah, at this point, pretty modestly. So the only one that of all these that really makes me consider changing my recommendations is BRCA2 at this point. That's the gene that's most clearly associated with aggressive prostate cancer. So for any of the other genes that are mutated, it's I'm not going to say it's a non-factor in clinical decision making for a guy with localized prostate cancer, but I'm going to minimize that as part of the counseling process. Again, just specifically for that patient's decision making. Now, I think the BRCA2 mutation is where it gets really controversial, and where we have to be cautious. So for the guy with intermediate or high risk disease, I'm going to definitely tell him, hey, this is potentially more aggressive prostate cancer than we think, and there's probably a higher risk of metastasis over the long haul than we'd like there to be. And no matter what we do, we may end up needing to use multiple forms of treatment. But still, we're having a discussion now today, and in the absence of a clinical trial, which would be really, really great, where we could offer maybe neoadjuvant PARP inhibitors someday. In the absence of a clinical trial, it's standard of care treatment. Now, that active surveillance, pay the patient if he has got Gleason 6 disease. For me, we'll have a clear discussion. If he's got high volume Gleason 6, we're going to recommend treatment. But if he's got low volume, very low risk disease, I will still likely recommend surveillance. What do you think?
So I think that is going to weigh on a lot. I look at Dr. Isaac's paper, and there's been Dr. Castro and other people have really shown that these men die earlier, even with once they have the gene, they tend to die earlier. So I do think it's a big issue. Can I jump into one thing? Heather and I are going back and forth a little bit on the swap card. So there was a question that came in about a man who had a family history of prostate cancer and high PSA and a lot of things going on with him, but he doesn't have a diagnosis of prostate cancer. Should he undergo genetic testing? And Heather is kind of on the side of the fence that he should. I'm kind of on the side of the fence, unless you prove to me somebody in the family has that mutated gene, you really shouldn't open the can of worms. So I'm curious about how you feel about that, Todd. Where would you weigh in on that?
I mean, I might ask Heather, and then that she might convince me otherwise. But in general, yeah, I would, I really discourage testing of unaffected individuals, meaning guys without cancer, and unless there's some other clear driver, family history,
yeah.
Or family history of a mom with ovarian cancer, and the mom's passed away, and he's really worried about his cancer risk. That's a really good indication, I think, for testing of somebody who's unaffected. But otherwise, I do tend to steer clear. I will say that if a patient who is unaffected but does not have prostate cancer and is considering germline testing, that's somebody that I refer to a genetic counselor also. Because I think Heather, aren't the risks?
Yeah.
The risks
So Heather is a little more in favor of testing this man.
Let me actually say, I was trying to, it may have been that I read it a little too quickly. So I think there's two questions. So what I thought Dr. Gold was asking was if there was hesitancy, what the advice was. I didn't fully capture in that question that there was a management question. So the management of that patient would follow the clinical family history of prostate cancer, but embedded in that was the question of if there's hesitancy. So my response was, what was the concern around it? Not that I was pushing that he must have it, but sometimes there are patients who have hesitancy. And I think understanding the hesitancy is important. Sometimes you can address it. And when you can't, or when there's somebody who's very anxious, that's when I actually do refer them to the genetic counselor for a longer discussion. So maybe it was just the question, the question.
No, I get it. And I'll tell you, GINA scares me a little bit. A 45-year-old, I'm going to deny him his opportunity for long-term disability care or life insurance. That scares me. And that's why I think a genetic counselor, I'm happy to pass that burden on to the genetic counselor to help navigate that decision. If you're 75 or 80 years old, not that you're old, but I mean, you're not going to worry about, long-term disability because you're probably not working. But anybody younger than that, it really scares me.
Yeah.
Specifically in the setting of somebody without cancer, right? You're saying.
Right. In particular, somebody without cancer, right?
And I think it's something where even though we're very excited about the possibilities, I think the obligation is to offer it. There will still be patients who have advanced metastatic disease who have concerns and don't want it either. And I think that's their choice. And there's not a mandate to do it, but I think there is a mandate to discuss it and then let people, get the information and then make the decision on their own, schedule in on their own terms. I certainly would not want anyone to do it if they were not comfortable. But I will say that there's, it's interesting with 23andMe and, Ancestry.com, there's a population of people out there who are just gung-ho about this kind of thing. So I think it's just important to meet patients where they are.
And to be fair, right, Heather, there's some push towards recommending universal testing among women, right?
You mean women with breast cancer?
No, I mean
just all
women, right? Is that not a?
Well, I think that's been proposed as to whether or not, but the details matter, right? So in the proposals that have been put forth, so Mary Claire King has put forth a proposal to do such a thing. The detail is it would only be for very high known characterized high penetrance genes like BRCA1 and 2, and with no reporting in VUS. You do not give that information out because simply not useful. So you only give the highest impact clearest signal data and you omit everything else if people want it. So that would be, that's important, because otherwise the VUS question really becomes, as you might imagine from what we've already been talking about, really, really, really problematic.
Yeah. Before we get to your talk, I want to look, there's two questions that I just caught online. One is there a way to predict radio resistance in prostate cancer using germline testing? And I would say, no, not that I'm aware of. There's always been, I think, some concern of increased risk of side effects of collateral damage from radiation in the setting of DNA damage repair mutations. And there's some data around that, but my understanding is that it's probably not as great as we've worried about. And we've definitely had many patients who prefer radiation for treating their localized prostate cancer in this setting, and we still offered it. And so I think that's one important thing to keep in mind. And the other question on here from Stacy Loeb is asking to talk more about our usage of metastatic biopsies and somatic testing. So I'll put that to you, Heather.
Yeah, we can get to that maybe also towards the end. I don't talk as much specifically about the somatic aspect because the focus of this was more on germline, but we are in the medical oncology setting doing more metastatic biopsies for treatment planning. We are doing more liquid biopsies in the right context. So I think there was a question about that earlier, and I think one of the things we're learning, and you might sort of make some intuitive sense, is that if you do liquid biopsies when the PSA is very low and the disease is very well controlled, you're more likely to get red herrings and sort of interference from either nearby white blood cell DNA that has no relationship with the cancer, or just false positives in general. So, but it's actually important to think about, because somatic testing is going to pick up depending on the test, germline and somatic. So you will get potentially more actionable findings from sampling the tumor than sampling the germline. So they're related, but they're not the same thing. And they ask sort of complementary but not completely overlapping questions. So it is important to think about. And I think it's possible, we'll see how the field evolves, whether or not there may be movement to doing somatic and then reflex germline. But I think there's a lot, I think, that has to happen, and whether or not that's the right thing, I think we can kind of consider that moving forward.
Yeah, sure. All right, so let's hand it over to you for this. So the last talk from Dr. Cheng is going to really review the impact of germline testing and its importance in advanced prostate cancer. Thanks so much.
Yeah, and then hopefully we'll have time for more discussion, because they're really great questions. Let me show my slide. I'm going to talk about germline testing in prostate cancer, sort of continuing on the theme, but with a focus more on advanced prostate cancer. Those are my disclosures again. And in the next half hour or so, I'm going to talk about briefly, I think it's been covered before, so I'll probably be able to go over it quickly. What proportion of patients with advanced disease have germline mutations? There's some updated data I just wanted to let you know about, specifically with localized high-risk disease. What therapies may be applicable for germline DNA damage repair patients with metastatic disease. So Dr. Gomella alluded to that early on. So I'll talk about PARP inhibitors, and I'll talk about pembrolizumab. What are some of the mechanisms for targeting DNA repair? And then what are the trials? I'm going to talk briefly about some trials that are ongoing in DNA repair deficiency, and I'm also going to talk a little bit about lutetium, and then open it back up for discussion, because we've had such great questions so far. So this I won't spend too much time talking about, but we're talking about inherited DNA, just to remind you, germline, which can be assessed by saliva or blood. One of the important aspects are, what is the risk of developing cancer? It can also be used as a biomarker for treatment decision-making, which is really maturing quite a bit in advanced disease. And that's the question there is, can a germline test be helpful in targeted therapy decision-making for prostate cancer? And then there's this sort of intersection that we're in, involving and considering genetic counseling, as particularly as we think of risk of other cancers, and then cancer risk in family members. So this is a schematic that I like to use when I talk about where we are in the disease spectrum and where it matters. So 1 in 10 men with metastatic prostate cancer or more carry inherited mutations in DNA repair gene, and that's in this latest disease setting right here. So here's early detection. We've talked a little bit about active surveillance and screening. That's over here. Treatment decision-making with definitive treatment of localized, intermediate, or high-risk disease with surgery, radiation, or with or without androgen deprivation. And then most of my patient or practice is genetics as it intersects with this advanced disease setting. So biochemical recurrence, non-metastatic CRPC, which is evolving also with our new imaging modalities, and then visible metastases, so hormone-sensitive or metastatic castration-resistant prostate cancer. So we've already talked about this paper. Here, I just want to highlight to you some of the other disease states that have been studied and reported on. So these are germline prevalences across DNA disease states. So the top is metastatic disease, that's 11 or almost 12%. And then there was a paper from Dr. Castro and her colleagues in a similar population in Spain that found 16%. In the metastatic hormone sensitive study, this is a single institution retrospective study out of Mayo of 700 patients, about 9%. And then in the intermediate high risk localized disease, because I think that's certainly one that we're paying close attention to, there was a pooled analysis of 5 prospective neoadjuvant studies out of the Dana-Farber of 200 patients that showed 9.5% prevalence. And this is unselected for family history. These are patients that are otherwise engaging in a neoadjuvant study, and I thought that was a pretty notable percentage. And then in the localized disease setting from TCGA, which is kind of a heterogeneous population, in 500 patients, it's about around 5%. So this gives you kind of a flavor. I think I think it's also where some of the historic data, the methods may have been a little different in the patient population somewhat. So this is a little more contemporary. So I think this is helpful to think about in assessing frequency. Okay, so now I'm going to talk a little bit about the treatment toolbox, as I call it, for advanced prostate cancer. Again, this is mostly for patients in this last kind of more advanced setting. In this larger box are treatments that we have available that are not selected by mutation. So this is what I would consider the general growing and impressive treatment toolbox. And I've added lutetium, LU177 PSMA 617 as anticipated, because as you're probably aware, it was reported as a positive phase 3 study at ASCO. So we're sort of anticipating that to be part of this toolbox. But the biomarker toolbox, which is a toolbox that's of particular enthusiasm or excitement for men who have germline mutations, includes these agents, and we've sort of briefly mentioned them already: pembrolizumab, which is an immune checkpoint inhibitor, rucaparib, which is a PARP inhibitor, olaparib, which is another PARP inhibitor, and then briefly I'll mention carboplatin, because it's in the advanced disease setting. We typically do not use carboplatin unless we have a good reason to do so, unlike breast and ovarian and pancreatic cancer. So that's an added agent in the toolbox. So here is a schematic of DNA repair and the different types of mechanisms of DNA repair in prostate cancer. So there's single-stranded breaks, and there's a team of genes that are involved in repair of single-stranded breaks. There's double-stranded breaks, which can be repaired either through homologous recombination or non-homologous end joining. And then there's mismatch repair here, which is different types of error correction. And as I've alluded to, about 20 to 25% of patients with metastatic prostate cancer have somatic mutations. So that's the germline plus the somatic only, the tumor only mutations in metastatic disease, and 12% or half of them have them in their germline. So what Dr. Gamella and Dr. Morgan had referred to as, or the hereditary breast and ovarian cancer as it used to be known, and I call it King syndrome. And then over here is the 5 to 7% with microsatellite instability high or mismatch repair. Those are the Lynch syndrome genes. So those are MSH2, MSH6, MLH1, and PMS2. 3% of them occur in all stages of prostate cancer. So there was a series out of Memorial which I think is this Abita et al. Article that showed that if they looked across all of their prostate cancer patients, there was about a 3% prevalence and 20% of them had Lynch syndrome. So they're small, they can be small depending on how you think about it, but they're important for all the reasons we've talked about already. And then PARP inhibitors and platinum are especially effective in this group, and then immune checkpoint inhibitors. So I'll talk a little bit more about that in the next few slides. All right, so very briefly, BRCA2 mutations in response to carboplatin-based therapy. So this is mainly as an FYI, because even though carboplatin has been around a long time, as I said, we don't usually use it for prostate cancer, but it can be extremely effective for patients who have these mutations. And there's just 2 papers that reported on this. We had a series, and then Dana-Farber also had a very nice series showing that this was effective. It's cost effective because it's old, and there's not somebody standing to make a profit out of carboplatin. So it's something to think about in the toolbox. And then the phase 3 PROfound study was reported and led to the approval of olaparib. I'm not going to go through this in a lot of detail, but just highlight a couple of things. So this patient population was metastatic castration-resistant prostate cancer with progression on either abiraterone or enzalutamide. They must have had a mutation in one of the qualifying genes, and I'll show more of that in a moment. These are them listed as either cohort A, which I would call the varsity team, which BRCA1, BRCA2, and ATM, and then cohort B, which you could consider like the JV team, less common, we just don't know as much about, but they were included in the analyses, and they were 2-to-1 randomized to either physician's choice or olaparib. And the physician's choice, I think, was enzalutamide or abiraterone, maybe docetaxel. So the primary endpoint was radiographic progression-free survival in cohort A, but they also looked at cohorts A plus B. And I'm not going to, again, spend too much time on this except to say that they looked at both. For cohort A, there was imaging, radiographic progression-free survival. There's clearly a separation in these curves if you just look at BRCA1, BRCA2, and ATM. And the interim overall survival analysis was also pretty, pretty separated, and so in favor of olaparib versus control. And then they also did analysis of A plus B. Remember, that's the varsity team together with the cohort B, the junior varsity team. And there was a separation, but you can see that that has it's narrowed a bit. And this did lead to the approval by the FDA of olaparib for patients post abiraterone and enzalutamide for these genes. Now, there's some caution, and the devil is always in the details. I won't go through this a lot, except to say these genes are not equivalent. So like any sports team, you might have a star that can carry the rest of the team, even if they're not quite as strong. So in the paper, they've sort of parsed out some of the genes, and you can look at BRCA2, which clearly, if you look at this line, olaparib is better. This is like an A plus, right? This is the star of the team, as Dr. Morgan had sort of also mentioned. And this gene, PPP2R2A, actually was very clearly not better, and that was or not included in the FDA approval. Most of the other genes are kind of in between, in part because there may just be very few numbers, and we just need more data and more examples to sort of fill in the gaps. So I think that's important to kind of keep in mind. There was a Triton-2 study, which was the study that led to the approval of rucaparib, and rucaparib is only approved for BRCA1 and 2, but this Dr. Abita and his colleagues et al. Very nicely parsed out gene by gene what some of the responses were. And the short of it is that they had limited radiographic and PSA response in men with alterations in ATM, CDK12, or CHEK2. So those appeared to be less predictive of response to rucaparib, whereas there may be a signal for patients with PALB2, BRIP1, FANK-A, RAD51B. And so basically the take-home point is that these genes are not equivalent, and we need a little bit more, well, not a little bit, we need more data to tell us which are most predictive of response to the treatments. They are in the FDA approval, so they are, or at least for olaparib, so they are part of the treatment toolbox, but just, a word of caution in terms of how enthusiastic we should be in terms of how predictive they're going to be. So there's some other I think research avenues that are really exciting in the pipeline to investigate other markers that may be better in predicting or complementary in predicting response. And those include things like looking for loss of heterozygosity, second hit, DNA methylation, loss of the function of homologous recombination repair, genomic footprints. So a lot of research efforts in this avenue, and hopefully that'll help improve our prediction algorithms for whether or not somebody's going to respond to these treatments or not. And if they won't, then maybe we need better clinical trials and more different strategies for those patients. So next generations, as I alluded to, is gene by gene. So we want to understand the risk to prostate cancer. We want to understand how it affects tumorigenesis, how it influences metastatic potential. So it may be that some of these genes affect one more than the other. They're more likely to cause prostate cancer, but may not necessarily lead to more aggressive prostate cancer. Or maybe they come into play when there is prostate cancer and they help drive metastatic potential. And then the biology also along those lines, does it predict response to treatment and then resistance? All of those together as a piece will tell us, how important is this? And so germline BRCA2 mutations are our sort of showcase example. We need to fill in the gaps with the other genes such as ATM, CHEK2, BALB2, and so forth. So one of the promises might be, as we move forward, thinking about how to find cancer earlier and then using targeted treatments potentially at earlier disease states for better outcomes if we understand them better. Okay, I'm going to talk a couple slides on pembrolizumab and its mechanism of action. So pembrolizumab is a monoclonal antibody treatment that blocks signaling of PD-1. PD-1 interacts with PD-L1, the PD ligand 1, which can be expressed on cancers, prostate cancer cells, other cancer cells too, as a way to protect the cell, the cancer cell, against immune recognition and T cell killing. So essentially, it's a sort of way for the cancer cell to hide and the immune system to be sort of tamped down or turned down rather than up. And so cancers that have higher background mutational burden, and particularly those that have mismatch repair deficiency, those are the Lynch syndrome genes, such as MSH2, MSH6, PMS2, and MLH1. They have this feature in their cancers called microsatellite high. So they have a higher, which is a reflection of having higher background mutation than normal. So what we might call neoantigens. So they're essentially more visible to the immune system. So they're more visible to the immune system. And then we block this step that says, you can get through that checkpoint, security checkpoint, let's say, and now the T cell can recognize the prostate cancer cell and kill it, essentially. And so this takes the brakes off the immune system, allows the immune system to recognize the cancer that has more neoantigens and is more visible to the immune system, and therefore take care of it on its own. So this is really exciting. It's, as I've sort of mentioned earlier, not something that is as common in prostate cancer, and there's a lot of strategies to try to surmount that and achieve the same kind of benefit for cancers that don't have this high neoantigen load. But in the meantime, there are patients out there who have high MSI high, or DNA mismatch repair deficiency. It's about 3% if you look at all prostate cancers in the Memorial series, of which a fifth of them had germline Lynch syndrome. And those did have, and a good proportion of them did have durable benefit to PD-1 blockade, such as from pembrolizumab. So we definitely need more numbers as we go, but I can tell you I've had personally a few patients of my own with Lynch syndrome who've had pretty dramatic responses to pembrolizumab and durable responses. So that's really exciting and important to kind of be aware of. In the interest of time, I'm not going to go through these rows one by one, because this list actually had to be updated since the last time we gave this talk, and it is changing very quickly. Mainly, I show a few of them just to highlight the fact that there is a lot of research activity and clinical trials ongoing with relevance to DNA repair defects. All of them would include germline mutations, not limited to germline. So also people who have them somatic mutations in the same genes, but a lot of really exciting strategies for combination therapies. So for example, rucaparib in a phase 3 study, combinations of a PARP inhibitor, niraparib with abiraterone and prednisone in the hormone sensitive setting in the amplitude study. We have a study at the University of Washington, which is induction chemotherapy followed by maintenance PARP inhibitor with rucaparib, which is a strategy that was proven to be effective in pancreatic cancer. So we'll see if it's also effective for prostate cancer. Neoadjuvant PARP inhibitor, as Dr. Morgan mentioned. And then, also exciting is Dr. Schweitzer has a study of a PARP inhibitor with an immune checkpoint inhibitor in the biochemically recurrent setting where we think there's a high likelihood of increased neoantigen load. So lots of activity and excitement. Stay tuned and maybe encourage your patients to consider these trials. All right. I want to spend a couple minutes talking about the VISION study. If you haven't already heard about it in the urology community, I think in medical oncology, we're really excited about it. This is lutetium-177. It's a radioactive beta-emitting particle, so it's like radiation. It's tagged to a PSMA, prostate-specific membrane antigen antibody, or recognizing antibody. So it essentially homes in on cells that express prostate-specific membrane antigen and delivers this beta-emitting particle, which can give rise to DNA damage, both single-stranded and double-stranded. So this is important for patients who may have deficiency in DNA damage repair. Here is, but the eligibility for this drug was not selected. So you do not have to have a DNA repair defect to be eligible for this, to be eligible for the VISION study. So presumably it won't be for that once it gets FDA approved. And here's the sort of separation of the curves for event-free probability in the paper that just came out from Dr. Sartor and his colleagues for this study. But the reason I bring this up is because, this may also prove to be better or worse with BRCA2 and other DNA repair mutations because it causes cancer cells to die through making DNA double-stranded breaks, which are deficient in cells, for example, with BRCA2 mutation. So there's already 2 papers, one that's suggested as a possible cause of poor response and one that actually reports it with an exceptional response. We'll have to stay tuned. I personally am hopeful that it will, that it may be more effective for patients with DNA repair alterations, but we'll just have to follow the data and see. All right. So along the lines of getting better data over time, I just want to introduce very briefly the PROMISE study, which is a registry study. So Dr. Morgan showed a slide of the PROGRESS study that Dr. Geary is leading for patients who have had germline testing for prostate cancer to help understand their experience with genetic testing, which I think is really important to think about how we can improve our methods of doing that. This study is a little bit different because it's also interested in making genetic testing available, but the long-term outcome is following patients with germline alterations with their treatments and their outcomes. So questions such as, does lutetium work better or worse for BRCA2 carriers? Does PARP inhibitor work better or worse, and in combination with other, should it be given before abiraterone or after abiraterone, or, those kinds of questions, not just looking at one trial experience, but the long-term trajectory of any given patient, and can we learn from that? We also have an arm to enroll patients with variants of uncertain significance to hopefully reclassify those variants and then also inform patients about therapeutic clinical trial opportunities. So, so that's the study. You can find it on clinicaltrials.gov. Patients can get registered. They can get a DNA saliva kit sent to them, and they get the results back. And it is shared with their physician so that urologists can also participate. And if somebody has a known mutation, they can also participate because we are most interested in patients who have germline alterations in order to follow their long-term treatment outcomes. But this is something that you may want to consider and join us if you're interested. So I think the goal here would be to capture the experience. We've talked already about active survey, some of the nuances of, what's the right thing to do in active surveillance. We talked about that BRCA2 is the gene we know the most about. What about these other genes? We really need to learn more about them. And really, we'd like to learn about their experience, patients' experience through the spectrum. And so that by learning about that and which treatments work better, worse, and timing, maybe we can intervene earlier so they don't get to this advanced disease setting. I would just love to, be focused more on this side of things and not and reduce my panel over here. So this will help us hopefully learn more about that. Okay, so in conclusion, 1 in 5 patients with metastatic prostate cancer have DNA repair mutations in their tumors. And are actionable with the treatments we've talked about. And 1 in 10 of them have those mutations in their germline or is inherited. So, so we are interested in finding both for both reasons of treatment, as well as the implications and the potential benefits for their relatives that can be life-saving. So I'm going to take out, last time I gave this talk, I said the potential implications for treatment. So now those potential implications are real because we do have now FDA-approved agents, 2 PARP inhibitors and immune checkpoint inhibitor, as well as platinum chemotherapy and more clinical trials in the pipeline. And so those potential implications are now real implications, and there remain important implications for family members. Molecularly targeted precision therapies are now approved, as I just said, for advanced prostate cancer and are available, and there's trials of combinations that are being studied in earlier disease states, which I think is really the most exciting part is to take what we've learned and move it earlier to hopefully change the natural history. And I hope I've shown you, and we've talked about, we could talk about further, is that gene by gene interrogation and longitudinal sort of follow-up and registries are going to be important for us to learn more, especially with the very rare variants that are uncommon, but may tell us a lot about biology and may help us learn more about even other scenarios. And throughout this whole session, I hope you can appreciate that urologists and urological oncologists, together with genetics providers and medical oncologists and radiation oncologists, are really a key part in realizing the benefit of these new, both dissemination, but also realization of how we can benefit from these treatments and then advance the knowledge to help our patients as thoughtfully and quickly as we can. So I think I have one more schematic. So this is, I like to end with a shared vision of cascading impact. So I talked a little bit about this sort of targeted therapies that I get excited about as a medical oncologist. And then also we've talked about the germline, which is 1 in 10 of men with metastatic disease. Half of the relatives, so half of our, any given man who has one of these mutations, their siblings or their children have a 50% chance of sharing that same mutation. And then hopefully, we can get them good genetic counseling, cascade testing, and have those relatives have tailored screening and risk reduction options. We didn't specifically talk about them today, but they're early detection and screening studies. I've listed them there. And then hopefully I've shown you some exciting possibilities for tailored curative treatment options. We know these things exist for breast and ovarian cancer and pancreatic cancer, and I hope we can do the same for prostate cancer. Oops, I think that's my last slide. So effective integration of genetics and prostate cancer clinical care can be a force multiplier against cancer. Thank you, and I'm looking forward to the discussion with the fellow panelists. Thanks.
Thank you. Thank you. Thank you. That's so good. I mean, it's actually amazing to think about. It's been 2 years since we've given this course, and it keeps changing big time. I mean, that I feel like that whole slide set was just 100% different.
Yeah.
So that's pretty exciting. And there's a lot of new data out there. There are tons of studies that are ongoing or being developed, and so it's pretty cool. Thank you. So all right, we have 6 minutes until we get to do the CME post-test questions. So I would like to drill down a little bit into kind of a patient who, this is for you, Heather, a patient who comes in with newly diagnosed, let's say high volume metastatic prostate cancer, and they have a BRCA2 mutation. We kind of talked about that in the localized setting, but what are you thinking in terms of your counseling and decision making in that for that patient?
Yeah, for treatment, you mean? So a couple, I think I try to get them on a clinical trial. I always try to encourage them to think about clinical trials. I think one of the things I didn't have time to show all the data for, but I think so far for BRCA2 mutation carriers, for example, we don't really know. There's a little bit of conflicting data, but I haven't been convinced that they respond less well to the conventional toolbox. In other words, abiraterone can work just as well, I think. Enzalutamide can work just as well. Docetaxel, in the hormone sensitive setting. If they have low volume disease, I might offer them, SWOG 1802 if that seems like of interest. We have Amplitude now, which is the study I mentioned, which is hormone sensitive metastatic disease. It's abiraterone versus, abiraterone versus abiraterone plus niraparib. It's PARP inhibitor. So that study would be an option if it was a known BRCA2 carrier. In the past, I think those are the two opportunities. But standard of care, we wouldn't treat them differently. Standard.
Yeah. So it doesn't make you more likely to recommend chemo or less likely to recommend chemo.
Probably not. Although I might, if it's somebody who's young. So I do have some. They tend to. I don't know if it's just my patient panel. I tend to be young. And because I think because of my interest in genetics, they often find their way to me. And so I probably do have patients who lean a little bit more towards chemotherapy. But I think all of the sort of standard of care options would be under consideration. And then it's really sort of patient preference nuances of the discussion and then trying to get people on clinical trials. One thing I will say, though, is that even though there's a lot of enthusiasm for PARP inhibitors, I do caution people not to do it off label too early, because then they can't get on a clinical trial. We know they don't work forever. And so they could be, missing out on an opportunity, because then they'll be excluded from PARP trials. They may miss an opportunity to be on a PARP plus something else trial. So I try to sort of say, let's not do things off label, because in the meantime, the field is moving so fast. We may have a trial or just more knowledge to apply to the situation.
Yeah, makes sense. So I want to touch on a couple of the questions in the chat. So Lenny and I both responded to somebody who asked about lifestyle modification. So let's go back to this patient with metastatic prostate cancer. Says, okay, what can I do? I've got a BRCA2 mutation and advanced prostate cancer. What can I do?
Yeah, I think really trying to do a lot of the things we recommend to all of our patients, trying to get on the right treatment, and then really thinking about all the supportive care measures and healthy lifestyle. So that includes, if somebody's not already at a healthy weight, to try to encourage them to get to a healthy weight, to exercise, to do, bone protective resistance exercises to help maintain their bones, make sure they get DEXA scans every 2 years to just make sure we're not losing sight of their bone health. We have dietitians on board, so really getting them hooked in with diet, with all their other health, if they have diabetes, if they have high blood pressure, we want to optimize all those things. Because what I tell people is, I expect to know you for a long time. We're making so much progress. We got to work on all your other health and make sure that is optimized so that you can get all these, cool treatments.
Great.
We use an easy term. What's good for your heart is good for your prostate. That's kind of our mantra. The other thing that we push really in daily care is you need a primary care doctor. All of those wonderful things that Heather just talked about, weight loss, sugar, all that kind of stuff. Most of us who are subspecialists, particularly those of us who are not trained in internal medicine like Heather, really don't have the time or the skill set. But I think patients, particularly with advanced prostate cancer, need to partner with the oncologist and a primary care doctor who looks at the overall health issues.
Yeah.
Because men with prostate cancer are more likely to die of some other horrific thing like a heart attack or something like that. So we got to always keep that in mind as well.
great points. And then I want to make sure we kind of clarify a couple key points that are in the chat. One is, there's this question of, well, which test do you order multi-panel testing, which one should I use? There's so many out there. And the answer is, as far as we know, all the commercially available tests are good. These are labs that specialize in this. Yeah, their panels differ a little bit, but I don't think any of us would say, oh, you should use lab X and not lab Y. They're good. And so no preference there. And then there's a question about, asking about the GPS score. And so it's really important to be clear about, the tests like GPS, which is Oncotype, or Polaris, or Decipher are not germline tests. These are gene expression tests that are used to assess the aggressiveness of localized prostate cancer using tumor tissue. And so this is kind of on the somatic tumor side of things. This is not on the germline inherited genetics side of things. So none of those tests give you any information about familial prostate cancer, heritable prostate cancer. Really, really important. And I think it's easy there's so much going on in this space. It's easy to conflate a lot of these tests.
Yeah, and can I add to that, Dr. Morgan? I just want to add one important point, which I think might have been covered in the pre-test quiz too, but I think it's really critical to understand that of the somatic tests, if you have a mutation like BRCA2 or you want to do dedicated germline testing, but the absence of a BRCA2 test on a somatic panel does not mean there isn't one there, because some of the panels for somatic will subtract out all the germline. So they really should not, you should not rely on that alone. You really should, it may lead to a necessity to reflex test, but you shouldn't assume that because it's not on the somatic, it's not there. That's really, really important.
Thank you. Awesome. Okay, we get to do the post-test now. So I've got to flip over. All right, well, that really concludes it. So can't thank everybody enough for joining, for participating online. Can't thank Dr. Gamella and Dr. Cheng enough. As always, it's just, I feel very fortunate to get to work with both of you, truly. So thank you. And I'll always get to learn from both of you. Hopefully see you guys in New Orleans.
Yeah, thank you too, Dr. Morgan, Dr.
Ciao. Thanks, everybody.
Thank
Have a good
you.
evening.
Stay safe, be well.
Yeah, bye-bye.